So just before I start, I just want to let you know that before this, I was not really. I really don't think that vasopressin was a good drug. However, after preparing this presentation, I changed my mind. So no conflicts of interest. So just want to give you a little bit information about vasopressin. So it was described in 1895 by Oliver and Schaefer, and they basically noticed that an extract of the posterior pituitary gland showed a significant vasoconstrictive effect. And vasopressin is synthesized in the paraventricular and supraoptic nucleus in the hypothalamus, and then it's released by the posterior pituitary gland to the systemic circulation. The most important effects are the antidiuretic effect and the vasoconstrictive effect. The antidiuretic is aimed to maintain the blood osmolality. When there is an increase in blood osmolality, vasopressin will be released and will act on the V2 receptor in the kidneys, especially in the collecting ducts, to increase the reuptake of water and to restore the serum osmolarity. And the vasoconstrictive effect is to maintain the blood pressure, and a decreased volume, more than 10%, will trigger vasopressin based on the and it will act in the V1 receptor in the smooth muscle to create vasoconstriction and to restore the blood volume and pressure. So what happened in septic shock is that we will have a relative hypovolemia. There's going to be a loss of intravascular volume through a capillary leak, and so this will be an ineffective intravascular volume. So how vasopressin behaves in these circumstances? So we can see that the normal level of vasopressin is low, and when we compare cardiogenic shock to septic shock, we'll see a significant difference of vasopressin production. Even in the early stage of septic shock, there will be a better amount of vasopressin in the blood system, but after 6 hours, it's going to decline. So what's the rationale of using vasopressin in septic shock? So as I showed you before, there is a relative vasopressin deficiency, so especially after 6 hours. There are other benefits that include regulates arterial tone, actually blocks and acts to attenuates the endotoxin and interleukin-1 to generate nitric oxide, and actually reduce the intracellular concentration of GMP, the second messenger of nitric oxide. Enhance the sensitivity of the vasculature to effects of catecholamines, and stimulates cortisol production. I just want to put this slide because I want to show you that the difference between vasopressin and catecholamines not only are the receptor pathway, but also the effect that it has during hypoxia and acidosis, while catecholamines is diminished with vasopressin is preserved. So, and also I forgot to mention that the effect on the renal vessels is vasodilation with vasopressin and constriction with catecholamines. So now I'm going to talk about the evidence behind this rationale. And first of all, I want to show you what EPIC has to say about it. So it's against it. Now we cannot order vasopressin without our staff authorizing this order. So if we are overnight alone, we'll have to wait until our staff comes in the morning to sign this order. So let's talk about the sepsis campaign and the guidelines about the management of septic shock. So when they talk about vasopressors, the recommendations are basically to maintain a MAP above 65, that norepinephrine should be our first line, that epinephrine will be the second option to add to norepinephrine. And they mentioned that vasopressin can be added to norepinephrine to basically to increase the MAP and also to decrease the dosage of norepinephrine. They also said that vasopressin shouldn't be a single agent. So there is a meta-analysis done by the Cochrane Collaboration Group in 2011. And the idea of this meta-analysis was to compare the 6 different types of pressors against each other and against placebo. So the conclusion of this meta-analysis pretty much showed that none of them has a difference in mortality. Their aim of the study was to evaluate mortality rates, and none of them show any benefit. No difference, not even norepinephrine, dopamine, none of them. So we're going to concentrate our right now on vasopressin against placebo. There are 4 studies, and against norepinephrine there are 3 studies. And as I said, as any other pressor, there was no difference. No difference in mortality with they tried vasopressin against placebo. No difference in mortality when they compare vasopressin against norepinephrine. What does this mean? None of the pressors has any difference in mortality. So let's talk about a little bit about those studies that were included in that meta-analysis. And one of them is the one that was published by Russell in the New England Journal of Medicine. Basically, this study was a big study. They pretty much enrolled like 800 patients. And those patients were in septic shock. They didn't respond to pressors. They started norepinephrine. And 12 hours later, they decided to enroll those patients, and they randomized the patients. One group was going to be treated with vasopressin, was a double-blind study, and the other group was going to be treated with more norepinephrine. I just want to clarify that this study, the randomization was after 12 hours. So remember that the levels of vasopressin in our blood, they go down after 6 hours sepsis. And the results pretty much didn't show any difference in mortality. No 28-day mortality in both groups were similar, and also the 90-day mortality was similar. Remember that the group on vasopressin is also getting norepinephrine. So both are getting norepinephrine as an open label and blinded norepi versus or vasopressin. However, when they decide to divide those groups and make a subgroup analysis based on the severity of the septic shock, and they describe and they define more severe septic shock when before randomizations the patients were getting more than 15 micrograms of norepinephrine versus the ones that are receiving less than that, and they divided in those 2 groups. And then we can see that in the less severe septic shock group, and the 90-day mortality is actually lower in the vasopressin group. What did this mean? I can say that the patients with more severe septic shock were really sick compared to the ones that we can make a change. And that group, vasopressin, did work and decrease mortality. And also, this study brought another important item to this discussion, and was the use of steroids in combination with vasopressin. Of those patients that were in that study, a significant amount, almost 600 of the almost 800 patients, received steroids at any point during the after randomization. And the relationship with steroids and vasopressin is significant. The corticosteroids increase the responsiveness of our body to vasopressin, and at the same time vasopressin increased the responsiveness of the corticotrophin release factor to generate ACTH. So both help each other. So after that study, the same author of the previous study decided to create a sub-study, a post-hoc study from that trial. And in that trial, they were trying to basically it's the same. They used the same trial, and because there was a significant amount of patients using steroids during the after randomization, they decide to divide it in between the group that received steroids versus the group that didn't receive steroids. And now we can see in this table that The group that received steroids is a significant amount, almost 600 patients. 293 patients received norepinephrine, and 296 patients received vasopressin. Both groups were similar in characteristics. And what they found was a significant difference in mortality. Vasopressin decreased mortality significantly, the 28-day mortality. I'm talking about the group, the patients that are getting steroids plus norepinephrine plus vasopressin. And it was significant. The Kaplan-Meier curve showed that the patients that were on vasopressin had better survival than the ones that were only on norepinephrine. Even side effects. Cardiac arrest was more frequent in the group that was getting norepinephrine versus the group that was getting vasopressin. So now let's talk about other benefits, not only mortality. So this study that was done by Lucier in France, this is a multi-center randomized trial. The number of patients is different from the previous one. This time we're only 23 patients. Patients with septic shock. Then the intervention was to add vasopressin versus norepinephrine. They start as a single agent. So something that came from this study is that 36% of the patients that were in the group with vasopressin required norepinephrine too. So the idea of this study showed that, well, the results show that there was no difference, and actually vasopressin failed to be a single drug, but in combination did work. And when we see some other secondary outcomes, we can see that the creatinine clearance was significantly better in the vasopressin group compared to norepinephrine. And also the organ failure. The SOFA is a sequential organ failure assessment, and showed that was better in the group with vasopressin. Also, the dose of norepinephrine that those patients received actually was lower in the group with vasopressin than the group that was not getting vasopressin. There's another study done by Martin. This study actually compared 48 patients that were having septic shock that were on norepinephrine, and they randomized to either use a combination of vasopressin plus norepinephrine versus norepinephrine alone. And their outcome was not mortality. Their outcome was hemodynamics. So we can see here there was a significant difference on MAP. The blood pressure was better in the group that was getting vasopressin, and the requirement of norepinephrine was lower in that group.
What kind of numbers, like how many patients?
And this study, 48. Yes.
Oh, sorry, and 48.
Yeah. There's another study. This is done by Patel. This study was not included in the meta-analysis that we reviewed before, but I put it here because I think it's very interesting. This is a smaller study. They only have like 24 patients total. This was, again, patients with septic shock, and they were on pressors, and they were randomized to vasopressin versus, as a single agent versus norepinephrine. So baseline, I mean, you can see that the mean pressure was similar in both groups. However, when we talk about other outcomes, like we can see the dose of norepinephrine that was used in the group with vasopressin was significantly lower. The urine output was significantly better, and also the creatinine clearance. This study was done by 1999. It's a smaller study. They only have 5 patients in each arm. The idea of this study was, again, compare vasopressin against norepinephrine. And we can see in the second table how the group, after 24 hours of infusion, the amount of norepinephrine, phenylephrine that they were using was pretty much none. And the systolic pressure was significantly better in the treatment group, the group that was requiring vasopressin. So the conclusion of my presentation is that, number one, I want to let you know that if you are considering using steroids, the combination of steroids with vasopressin showed decreased mortality in septic shock. And you also have to take in consideration the other benefits that vasopressin can give to your patients. So I want to special thanks to Dr. Rivers that helped me with this presentation. And now I'm going to let my colleague